Understanding Medicine.
I'm Professor Aziz Rehman, and from today we are going to start a new series of lectures uh, about kidney diseases, and this is going to be an introduction. Uh, I think before we discuss different symptoms and signs and different laboratory investigation, we have to have an overview of kidney structure and function. Kidney is one of the very fascinating organ and extremely essential for our life. And of course, life is not possible if kidneys are not functioning properly. So it is very important to have in-depth understanding of kidney anatomy and kidney function before we can understand various diseases. Now these are two kidneys. Most people have two kidneys. There may be one rare patient who has just one kidney congenitally, one may be absent, but typically we have two kidneys. They are anatomically two structures, but they function as one organ. So, and this is right kidney and left kidney, and this is the shape, the bean shape, and you have arterial supply, and then you have venous drainage. And this kidney, it consists of many functional units called nephrons. I will show you later, and not shown in this picture, there are adrenal glands sitting on the top of both kidneys. Right kidney is at slightly lower level because of the presence of liver here, and the left kidney is slightly on the higher side. Both are usually same size, but there could be some disparity in sizes. If there is too much disparity, then that might suggest renal agenesis or renal artery stenosis. These are the ureters. The kidneys, they take blood from the arteries and then filter it into the urine that passes into the ureters, and the remaining blood comes back into the venous system. So this is the very fascinating system. I repeat, there are two kidneys, but they function as one unit. Like other organs, kidneys also have a lot of reserve. So that means one kidney is actually enough. That is why we can even donate one kidney to somebody who needs it. If you cut the section, and this picture shows adrenal glands, although anatomically sitting on the kidneys, but they are functionally quite different organs. Although there is some interaction between kidney and adrenals, but they are actually just separate organs. You can see these are the calyces, and this is cortex. Cortex consists of millions of nephrons, and these nephrons, they make urine, and that urine comes into this collecting system, and then this is the pelvis of the kidney. Then it is drained down into the bladder and then ultimately passed. So this is very interesting. I think now we will have a microscopic view of this kidney and to have a better understanding. Now this is the typical one nephron unit. There are millions of nephrons in one person. Now we know that different people, they may have different number of nephrons, and one theory says that if you have lesser nephrons, you may be more likely to develop hypertension or other kidney diseases. But this is not yet proven. Everybody has millions of nephrons, and this is a typical functional unit. Now let me show you. This is artery. This brings blood into the glomerulus. This structure is called glomerulus, and this actually consists of a tuft of capillaries. Now the kidneys also are unique to have this unique system of circulation. These are arterioles, we call them afferent. Anything which brings blood to a structure is called afferent, afferent with A. And this is tuft of capillaries, and fluid is filtered into this space called Bowman's capsule. And then it goes on to the tubules, and the blood goes back into, not into veins, but into the afferent system. So glomerulus is supplied by afferent and drained by an efferent with E. So this system then goes further down and make further arteries and arterioles. It passes along the tubule so that it provide capillaries and then absorb many things like fluid and like sodium, like chloride and many other essential things, glucose along that. And this the waste water goes down and then comes to this collecting tubules. There is a very complex system. This Bowman capsule goes the first part and then loop of Henle, and this is the loop of Henle. It goes down into the inner part of the kidneys called the interstitium, then comes back and then again goes back into the pelvis. So many nephrons, they have this system, and very interesting. Few points which needs to be highlighted. Almost a large amount of fluid is filtered into the glomerulus. So 20% of our blood circulation actually goes to the kidneys, and then most of it is then reabsorbed. If there was no such mechanism, we would develop dehydration within hours. So most of the fluid, 99%, is reabsorbed. And all essential nutrients like glucose is also almost completely filtered into the Bowman's capsule, but it is almost completely absorbed by a system called SGLT2 and also SGLT1 proteins. So this is a system. So the things could go with the glomerulus, things could go wrong with the arterial system, things could go wrong with the tubules, and things could go wrong with the interstitium of the collecting system. So that is why we have various types of kidney diseases. Now let's have a more closer look to this one, on this one. Same, I think now you can see it better. Uh, I think further elaboration is not necessary, but I'm going to show you how kidney filters and how electrolytes are reabsorbed in another slide. And this is the one. You can see this kidney, blood goes into the kidney and goes out of the kidneys through the veins, and this is the urine is formed and then it is drained into the ureter. And this is the mechanism, and let me enlarge this one. Yes, this is one functional nephron, blood coming from the arteries, afferent arterioles, glomerulus, going back to the efferent, and then making these loops around the tubules. This is the Bowman's capsule. Fluid goes like this, and then the descending loop of Henle. This is called loop of Henle. This is a thick part. This is a thin part, and then this goes like this. This part is highly hypertonic. This part. So fluid is sucked out of the tubules by the hypertonic interstitium. Of course, vasopressin also regulates this one, comes back, and then ultimately it goes into the bladder. Many such nephrons, they ultimately they drain into the same collecting ducts and then urine is formed. So I hope this picture will make your concept more clear. So this is just an introductory lecture. You have read all this stuff in your physiology and anatomy, but I think since we are going to start this series of lecture on kidney, it is important to revise our knowledge. This is again a nephron, but I have taken this picture to show you another very important structure called this is a system tubuloglomerular feedback. Now, once these fluids and electrolytes are drained into the tubules and then come back, this part of the tubules, it comes very close to the this afferent vessel. This is the afferent arteriole. This is afferent arteriole, and this is the distal part of the nephron, the tube, where the fluid is going. Now there is a part of the system here called macula densa. Now this macula densa can sense the amount of salt and amount of water passing through this. This gives signals to the afferent arterioles, and that makes certain adjustment in its caliber and adjusts the blood flow. For example, if too little sodium and too little water is coming here, it would send the signal to the afferent arterioles to dilate the vessel and to bring more filtrate into the tubules. So this is how kidney adjusts our body volume and body electrolytes. So kidney has extremely important role in water homeostasis and electrolyte homeostasis, and also many other functions which I'm going to show you in another slide. So let me one very important function of kidney is regulation of blood volume and blood pressure. Now there are many mechanisms which regulate blood pressure, like our sympathetic nervous system and the tone of our vessels, the amount of blood volume, the heart function. But I think the ultimate responsibility of regulation of blood pressure and blood volume is that of kidneys. How it does it? First of all, angiotensinogen is a protein which is produced by our liver. Now, liver is made for producing proteins, and it produces millions of proteins, and one of them is angiotensinogen. This protein is circulating in the blood, but it has got no function until it is converted into angiotensin 1 by an enzyme called renin. This renin is produced by kidneys, and in response to dehydration, in response to hypovolemia, in response to hypertension, in response to water depletion and sodium depletion. So all these things tell the kidney to produce more renin, and renin would convert angiotensinogen into angiotensin 1. Angiotensin 1 has got some effect on the blood vessel. It can constrict blood vessel, and it can also stimulate aldosterone, but very mildly. And the major effect is that of angiotensin 2. Angiotensin 1 is converted into angiotensin 2 by an enzyme called angiotensin converting enzyme inhibitor. Angiotensin converting enzyme 1. This can occur in many parts of the body, but mainly in the lungs. So once angiotensin passes through the lung capillaries, ACE1 converts into angiotensin 2. Angiotensin 2 is very potent vasoconstrictor, and it also stimulates aldosterone. So once angiotensin 2 is elevated, it will increase the blood pressure. And once a specific level of blood pressure is achieved, then it would stop further conversion of angiotensin 1 into angiotensin 2. So this is very important. Angiotensin 2 has got vasoconstrictor action mainly, but actually there are two type of angiotensin receptors. One is it is called 1 and 2. One is vasoconstrictor, 2 is dilator. Ultimately, it gets converted into metabolites by ACE2. This became popular when we had this COVID, because COVID virus attaches to ACE2. So then metabolites, they have vasodilator action and vasoconstrictor action, and ultimately excreted. Why I am discussing this in the context of kidney diseases? Because all this system is regulated by the kidneys. So unless you have functional kidneys, it will be very difficult to achieve a good homeostasis in your body. Different functions of kidneys, they are actually numerous. I think first of all, water homeostasis. Whatever we drink, almost all of it passes through the kidneys. At any time, kidneys are receiving 20% of total cardiac output, and minus proteins and macromolecules and the cells, all plasma is filtered into the glomerulus. And that then most of it is reabsorbed, and this is regulated by these hormones. So water homeostasis is very good. Sometimes we drink a lot of water, extra is excreted by the kidney, and sometimes we don't drink water, and then kidney try to preserve water so that you do not develop dehydration. Then blood pressure regulation, extremely important role. Excretion of waste products. In our body metabolism, many waste products are produced and they have no use in the body. In fact, they have toxic effect, and one example is creatinine, and these are ultimately excreted by the kidneys. Electrolyte balance, we need to have a very accurate and precise level of sodium and potassium and calcium and phosphate and alkaline phosphatase. All this is regulated by the kidneys. Kidney will make sure that we reabsorb maximum sodium, because sodium has to be kept in the extracellular fluid, and potassium is mostly excreted by the kidneys because the extracellular potassium is usually very low. And preservation of nutrients, and I think the example I like to give would be glucose. Now, glucose is filtered into the glomerulus because the capillaries do not pose any resistance. All the glucose which circulates in the plasma goes to the nephron, and almost all of it is reabsorbed, minus very small fraction those who have renal glycosuria. Their renal threshold may be low and they may excrete some glucose. And in diabetes, when your glucose level goes up, then and when it exceeds 180, the so-called threshold of kidney, the extra is excreted into the urine. But normally kidney preserves every single molecule of glucose that passes through the nephron. It's extremely important because whatever we eat, ultimately it gets converted into glucose, and glucose is our main fuel. So it has to be reabsorbed. Otherwise, we would end up in hypoglycemia in hours after eating meal. Gluconeogenesis, whenever our glucose gets low, gluconeogenesis is a phenomenon where glucose is actually synthesized from fats and from protein, and this is mostly done by liver, but after liver, kidneys also play a very important role. That is why people with diabetes and kidney disease are more likely to develop hypoglycemias. Erythropoietin production, and this is a hormone which is a stimulant for bone marrow, particularly RBCs. So if somebody has kidney problem, his erythropoietin level will be low, and then the patient would develop anemia. So that is why in the management of chronic renal failure, many times we give erythropoietin as injection. Vitamin D activation, the vitamin D, whatever we ingest in the form of food or supplements or whatever vitamin D is made in our skin, is not active. It has to pass through two steps of activation, and first one is in the liver, the second one is in the kidney. So this process is also very important. That is why people with kidney disease, they tend to develop bone disease, because vitamin D is not activated. Excretion of drugs, whatever we take in the form of drug with whatever intention, these drugs are perceived as potential toxins by the body. So some drugs are excreted through the kidneys, some are excreted through the liver, many are excreted by both mechanisms. Some drugs which are excreted only through kidneys, there is a risk of accumulation when there is a kidney disease. One example is metformin. So you have seen that there are a number of functions performed by the kidney. So that is why kidneys are extremely important. Now let me show you some common clinical features if there is a kidney disease. Common kidney diseases. There could be generalized edema. So since kidney regulates our water contents, so if kidneys are not excreting water, it could accumulate in the body. Plus, if somebody has proteinuria, his serum protein level may be low, and protein in the blood is needed to keep fluid within the vessels, so that patient will also develop edema. So patient with kidney disease is likely to develop generalized edema because of two reasons. Number one, overall water retention. Water is not excreted. Number two, if there is proteinuria due to glomerular disease, there is possibility that water actually leaks out of the capillaries. So these two reasons, an experienced person can tell the pattern of edema and kidney disease. In nephrotic syndrome, proteinuria, there is accumulation of fluid on the ankles and or in the scrotum and the back. And in acute glomerulonephritis, there may be accumulation of fluid around your eyes also. But overall, there is retention of water. Reduce urine output, there may be some reduction, there may be significant reduction, or there may be sometimes complete shutdown. We call it oliguria or anuria. So I think that is another symptom. Dysuria, and this is mostly actually symptom related to the urinary bladder and prostate and urethra, but if there is urinary tract infection, then you could have this discomfort in passing urine. Hematuria, again, if somebody passes blood in the urine, it could be related to some bladder problem, or in women it may be just menstrual blood. But if those possibilities are ruled out, it may be coming from the renal system, it could be coming from the glomeruli. In that case, it would indicate glomerulonephritis, or it may be coming from the pelvis of the kidney due to kidney stones or maybe some tumor. Then hypertension, most patients with kidney disease, especially those who have some kidney failure, they are likely to develop hypertension. Pallor, because of deficiency of erythropoietin, people with chronic disease, chronic kidney disease are likely to develop anemia. Then many others actually. It's a very, very complex, because in chronic kidney disease, kidney failure, there is retention of so many waste products, so many solutes. So there could be any symptom actually related to brain or heart or lungs or stomach. Every organ is affected. So there is actually a long list of symptoms which you could develop in kidney failure. Common types of kidney diseases. Now please, just a reminder, this is only an introductory video. All these diseases I'm going to discuss in detail later. For example, first of all, glomerular diseases. This is further divided into many diseases like diabetes, hypertension can affect glomeruli, autoimmune diseases can affect glomeruli, amyloidosis can affect glomeruli, and similarly glomerulonephritis, if I have not mentioned glomerulonephritis, autoimmune disease, they can affect glomeruli. So there are many diseases which can affect glomeruli. If glomeruli are affected, your GFR would go down, and also you're likely to retain all the toxic substances. Then glomerulonephritis, autoimmune diseases, diabetes, hypertension, and infections of kidney. There are various types. There could be pyelonephritis, there could be some other kinds of infection, there could be just cystitis. So these, and then occasionally tumor. There is a common tumor called renal cell carcinoma, and that is also one of the diseases. Of course, there is a longer list, but this is a brief list. Diagnostic tests for kidney diseases, very basic introductory concepts. Blood tests is usually done to measure creatinine, blood urea nitrogen or blood urea, and on the basis of creatinine and also patient's gender and patient's ethnicity, we calculate eGFR. eGFR is estimated glomerular filtration rate. Very important parameter. There are a number of formulae available on the net. I think you can use any one of them. Detail I will discuss later. I'm going to make one whole lecture on GFR actually. But whatever calculator you use, whatever formula you use, it is best to follow the same. Because if you're treating somebody with kidney disease, you are actually interested in the trend of GFR. You may not be interested in the absolute value as much as you are interested in the trend. So if you follow the same formula every time, then you will be able to see if the trend is going favorably or otherwise. Arterial blood gas, because patient with kidney failure may develop acidosis, so I think arterial blood gas will be helpful. Urine test, very important, and this could be done with dipstick, which would measure the glucose and proteins and many other things, ketone bodies, and microscopy. With microscopy, one would be able to see if there are any red blood cells, white blood cells, casts, or other stuff. So this microscopic examination of urine is also called non-invasive kidney biopsy. Of course, it is not a biopsy, but the point is that it gives you so much information. A careful microscopic examination of urinary sediment can be very, very helpful. Imaging studies like ultrasound is usually the first line test, ultrasound, and then followed by CT scan and CT, IVU, CT, KUB, or sometimes MRI. They may be needed in appropriate cases. Finally, kidney biopsy. Of course, it's an invasive test, but particularly in patients who have unexplained proteinuria, those who have glomerulonephritis, I think they need kidney biopsy, and this is usually done by a nephrologist. It's a true cut biopsy, and a small piece is taken that is examined under microscope and then also under electron microscope and immunofluorescent microscope. So, estimation of GFR, why need it? Because this is one function of kidney which we always monitor. If somebody has developed kidney failure, then his GFR is likely to be low. Normally, the range is between 90 to 120. So we need to monitor kidney function by estimating GFR. There used to be various methods. In your physiology, you must have heard about inulin clearance. Inulin is a substance which is non-toxic. Once injected into the body, it is filtered, all of it is filtered into the nephron, and all of it is excreted into the kidney. So if there is a substance which is completely filtered into the glomerulus and then not absorbed at all, that may be used to measure GFR. But this is very, very cumbersome, hardly ever used these days. Creatinine can also be used to measure GFR, but problem is that the creatinine is filtered into the glomerulus, but some more creatinine is also secreted by the renal tubular cells. So I think this would typically overestimate the GFR. Opposite is true with urea. Some urea is reabsorbed, so urea would underestimate GFR. Luckily nowadays we have this something called cystatin. Now cystatin is a substance which is present everywhere in all diets. Every human has this cystatin, and it is very similar to inulin. So without actually having to inject something, and we can estimate GFR using cystatin. Cystatin may give you more accurate value, but creatinine is good enough. For routine purposes, we estimate GFR based on one's creatinine. Now, based on age, gender, ethnicity, and serum creatinine, these are calculated. There are various formula. Some consider more parameters, some less, but I think my suggestion is that you use just one, because you in one individual, whatever formula you use the same every time, because you just want to know the trend. You're not actually interested in specific number. Various online formula are available. Very, very briefly, kidney disease, whatever the cause may be, whether it is diabetes or it is hypertension or it is some drug intoxication or glomerulonephritis, pyelonephritis, amyloidosis, all kidney diseases, once kidney failure occurs, it behaves the same way. And this is a grading system. GFR more than 90, but with a background condition would be 1. And then if it is above 60, but of course less than 90, it would be CKD 2 and 3 and 4 and 5. People with CKD 5 have GFR less than 15. That is critically low, and that is not sufficient to sustain life for long. Maybe for few days to few weeks life is possible, but not for longer. So most patients with CKD5 would require some kind of renal replacement therapy. Complication of kidney diseases, hypertension is one, fluid retention, and fluid retention is not just edema, it actually can lead to pulmonary edema, it could lead to heart failure, it could lead to encephalopathy. So fluid retention is a very, very big issue. Anemia because of absence of erythropoietin, electrolyte imbalance, all the electrolytes are excreted by the kidney. So people with kidney failure are likely to develop sodium abnormality, potassium usually goes up, phosphate also go up, sulfates also go up, urate also go up. The acids they accumulate in the body, so there may be wide anion gap type of acidosis. Calcium and bone, because vitamin D is activated by the kidney. Those who have kidney failure, they are likely to have hypocalcemia, secondary hyperparathyroidism that could lead to bone disease. Treatment principles, of course, we are just discussing the outline. The treatment principle of kidney disease, first of all, prevention. Kidney is very vulnerable. So whatever we eat or drink, particularly in the form of drugs, medicine, you have to be very careful. Some drugs are known to be very nephrotoxic. Some are less nephrotoxic. So I think a physician would decide which medicine has to be given. Of course, you have to take a chance. Potentially, I believe any drug could be nephrotoxic, but some are well known. So I think you have to be careful about your medicines and control underlying disease. If you have a medical condition which can cause kidney disease like hypertension, diabetes, that has to be well controlled. And unloading kidneys. If kidney failure occurs, all our organs have reserve. If there is significant reduction in kidney function, you may still be working all right, but you can unload your kidneys by regulating your diet. Now, those diets which are rich in potassium, which are rich in phosphate and sulfates, and those diets which can lead to more creatinine formation like proteins, meat, they should be restricted, and salt should also be restricted, particularly sodium. And then medication, many medication may be used, like furosemide is used, and vitamin D active form is used, erythropoietin is used, and other drugs are used, depending upon the disease. If somebody is having this autoimmune disease, then immune modulating drugs are also used. Renal replacement therapy will be the last step, and hopefully we can manage patient without this one. But renal replacement therapy refers to either one or the other type of dialysis. It could be peritoneal dialysis, there could be hemodialysis, or it could refer to renal transplant. So this would be an ultimate thing, and luckily this facility is available, and luckily we have 2 kidneys, so any donor, matching donor, can donate 1 kidney. So this is an outline of kidney diseases. With that, I'd like to thank you for watching this video. Please join my channel, and I really look forward to see you in the next 7 or 8 lectures related to various kidney diseases. Thank you. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine.